Hi everyone, so today we're going to be talking about endotracheal tube insertion. So endotracheal tube intubation is a critical procedure used to secure a patient's airway, particularly in emergency situations or critical care. This intervention is often necessary when a patient is unable to maintain a patent airway independently. So this can be seen in cases like respiratory failure, severe trauma, or altered mental status. It is also routinely used to facilitate mechanical ventilation. The procedure involves insertion of an endotracheal tube, ETT, into the trachea, usually via the oral route to establish and maintain effective ventilation and oxygenation. So moving on to anatomy and physiology, starting in the oral cavity and pharynx. So this area includes the mouth where the ETT is inserted, and the mouth must accommodate for the laryngoscope and the tube as well. The oral pharynx is the passage between the oral cavity and the larynx. This is the first anatomical structure that the tube passes through. After that is the tongue, which must be displaced with a laryngoscope blade to visualize the laryngeal structures. Following that is the teeth and lips, which must be protected to avoid trauma during the intubation.
Okay, next we're going to go over pathophysiology leading to intubation. There's two types of failure that can lead to respiratory failure, and that is ventilatory failure and oxygenation failure. In ventilatory failure, it is defined as an oxygen intake and perfusion that leads to ventilation-perfusion mismatch. And this can be caused by physical problems with the lungs, the chest wall, a fault in the respiratory control center in the brain, and poor function or atrophy of the respiratory muscles. And then you can have oxygenation failure. In contrast to ventilatory failure, air and chest pressure are normal, but oxygen does not perfuse into the bloodstream. This can be caused by diminished or impaired diffusion of oxygen at the alveolar level, right to left shunting of blood in the pulmonary vessels, and breathing air with low oxygen, or it can even be abnormal hemoglobin levels. And lastly, you can also have a combination of ventilatory and oxygenation failure that can lead to acute respiratory failure. And acute respiratory failure can be classified with the following abnormal ABGs. That is a partial pressure of arterial oxygen of less than 60 millimeters of mercury, a partial pressure of arterial carbon dioxide of more than 45 millimeters of mercury, and finally an arterial oxygen saturation that is less than 90%. And then dysfunctional organs involved, we have the oropharynx, trachea, and the lungs, of course. In these systems, you can have increased secretions or sputum production. You can have decreased alveolar surface area. You can have physical damage to lungs or airway. And then you can have lung scarring or atrophy of the accessory respiratory muscles. Then the brain can also be affected and change the respiratory drive. That is, you can have drugs causing central nervous system depression, tumors or cysts affecting the respiratory center of the brain, or thrombosis or bleeding that can affect the respiratory center of the brain and decrease respirations. And the signs and symptoms that we can expect for someone going into respiratory failure leading to intubation is a shortness of breath, as well as increased respiratory rate and decreased SpO2, decreased respiratory rate in cases of CNS depression, productive cough, bronchi, crackles, wheezes, or absent lung sounds in the lung fields, decreased level of consciousness or an inability to protect the airway, and finally you can have facial, neck, or chest-related trauma that can cause or lead to patients in needing an intubation.
Prior to ET tube insertion, a person requires oxygen in order to delay hypoxia. They also require a sedative. So the sedatives we can choose from include etomidate, ketamine, propofol, and midazolam. After sedation, they need to be paralyzed, and this can be achieved through paralytic agents such as succinylcholine or rocuronium. So you can choose between those two. Succinylcholine is faster acting, but rocuronium has fewer side effects. Intubation should not last longer than 30 seconds. If it is longer than 30 seconds, oxygen administration is required once again. Once intubation has been achieved, we want to ensure proper placement through the use of a chest X-ray. Once all of that has been verified and placement has been confirmed, we want to make sure that we are managing pain, anxiety, and sedation by titrating medications adequately. So we can use midazolam and propofol for sedation, morphine for pain, Ativan for anxiety, and haloperidol for delirium. So we also want to make sure that we're checking the ABGs that the doctor orders, because we want to monitor the person for respiratory alkalosis or respiratory acidosis.
Moving on to nursing interventions. So before ETT insertion, nurses need to prepare and confirm all necessary equipment is available and working, such as a bag valve mask, suction, oxygen, and intubation tray, which holds things like the ETT, silets, laryngoscope blades, etc. You also need to assess the patient's baseline vital signs, respiratory effort, mental status, and attain ABGs for that baseline information. You also need to position the patient into a sniffing position by placing a towel or blanket under their head. Lastly, you need to pre-oxygenate the patient by administering 100% oxygen using a bag valve mask for a few minutes prior to intubation. During the procedure, you need to keep the patient in that sniffing position to allow for clear visualization of the vocal cords. You also need to continuously monitor vital signs to help identify any complications during intubation, like hypoxia, arrhythmia, or hypotension. And then you need to be prepared to hand equipment to the doctor or CRNA as needed and assist with confirmation of placement. After the placement is done, you need to confirm the tube placement by auscultating the bilateral lung fields and the epigastrum. What you're looking for here is for symmetrical chest rise and verifying with the chest x-ray as well, which is the golden standard. After that, you're going to secure the ETT using tape or a securing device and note the centimeter marking at the lip to know how far the tube went in. Once secured, you need to document the tube size and type, the insertion depth at lip, the cup inflation volume or pressure, the ventilator settings, the patient's tolerance, and the confirmation methods. An example of this would be X-ray or auscultation. Finally, continuous interventions would be to maintain airway patency and ventilation by suctioning as needed and assessing for secretions and breath sounds. You also need to make sure to keep cuff pressure in the therapeutic range, which is usually 25 to 30 centimeters of H2O. Monitor ventilator settings and alarms every 2 hours. Obtain ABGs. Monitor for signs of hypoxemia or patient ventilator asynchrony. You need to prevent skin breakdown and ventilator-associated pneumonia, and ensure adequate nutrition and hydration as well.
So complications from endotracheal intubation can happen before, during, and even after extubation, so it's really important for us to stay vigilant at every single stage. Let's start with airway complications. The tube can shift either upward, where the cuff sits at the vocal cords, or downwards into the right mainstem bronchus, causing unequal chest rise or absent breath sounds. The tube can also become obstructed by mucus, kinking, or even if the patient bites down. And also, unplanned extubation is a very real risk, especially if the patient is agitated or poorly sedated. So it's really important to have those tubes secured, and we monitor those patients closely. Moving on to tissue injuries, the tube can put pressure on the trachea or the larynx, especially if the cuff is either too tight or the tube size just isn't right. This can cause swelling, strictures, or even tears, and may result in infections, vocal cord paralysis, or decreased lung function. These patients may have difficulty breathing, a sore throat, or trouble swallowing after removal. Additionally, pressure injuries can also affect the lips or the nose, which is why frequent repositioning and oral care are extremely important. For lung injuries, we need to watch out for barotrauma or volume trauma. Basically, too much pressure or volume can cause a pneumothorax or air leaks. The high oxygen levels can also damage lung tissues and can lead to atelectasis, so it's really important to use conservative oxygen and monitor those PEEP settings. Another really big risk is ventilator-associated pneumonia caused by aspiration secretions. We as nurses can help prevent this through oral care, suctioning, and elevating the head of the bed. And finally, the other complications to be aware of include dysphagia or aspirations, cardiovascular effects, GI issues, acid-base imbalances, and psychosocial effects. From preparation to placement to post-care, every single step is essential to ensure that the airway stays secure and the patient is ventilated and oxygenated effectively. By providing comprehensive care, we can balance holistic support, promoting recovery, safety, and patient advocacy. Let's also remember that intubation is a very invasive and anxiety-provoking, often limiting communication. Here we can apply Jane Watson's Caritas Process 4 by being present, using gentle touch, explaining the procedures clearly, and advocating for comfort, and lastly, involving the family. This helps to create a trusting and supportive environment even when communication barriers exist.